Pleasure to introduce Dr. Barry Stein, who's a radiologist from UConn and a true imaging guru, and you'll see what I mean by that in a few minutes. He's going to talk to us about imaging techniques to evaluate the relationships between the superficial and deep system.
Thank you very much once again for inviting me to participate in this symposium. I don't have any disclosures for this particular talk. A disruption in either the deep or superficial venous system can present, patients can present with varicosities, lower extremity edema, deep venous thrombosis, as well as the sequelae of venous hypertension. Broadly speaking, the clinical masqueraders of lower extremity venous insufficiency can be categorized into suprainguinal and infrainguinal. The suprainguinal entities include pelvic venous incompetence, vascular malformations, May-Thurner syndrome, as well as some of the tumors that can obstruct the IVC. And infrainguinal includes the complex venous variants and lower extremity vascular malformations. One of the more common suprainguinal entities is pelvic venous incompetence, and the history, the diagnosis is made primarily with a very classic clinical history that is related to gravity-dependent symptoms, including pelvic pain, which is worse when standing with exercise, worse at the end of the day, better in the morning, and most patients also complain of dyspareunia. But of course, most of our patients that present with low extremity varicosities don't really primarily present with this symptomatology. So we should at least suspect or think about this entity when our patients present with atypical distribution of lower extremity varicosities, as well as visualizing varicosities that appear to be emanating from the pelvis. The varicosities tend to be more painful when patients have associated pelvic venous incompetence, and it's at least suggested by many that embolization of the variant vein incompetence is preferable before treating the non-truncal varicosities to prevent recurrence, as well as improving post-ablation symptoms. Some of the non-invasive techniques to confirm the clinical diagnosis of pelvic venous incompetence include pelvic ultrasound. In my practice, I prefer to perform these in an upright position to simulate or at least elicit the reflux, as well as perform this with Valsalva maneuvers. But primarily, magnetic resonance phonography is the most